Let's get rid of the assumption of vertigo treatment. I would like to mention the topics of this series. First, I will talk about what diseases are associated with inner ear vertigo, and then I will talk about the new treatment for Meniere's disease. Next, let me give you what diseases are associated with vertigo from the brain central vertigo. Then we will discuss how to distinguish between dangerous vertigo and central vertigo, and discuss specific cases. I will also have a talk about benign paroxysmal positional vertigo, which at first glance appears to be caused by the inner ear, but is the brain the cause? And then, finally, I would like to explain the close relationship between cervical spine abnormalities, stiff neck and shoulders, and vertigo. For more detailed explanations and examples, as well as what medications to use, please refer to my book, Vertigo is Not Always Caused by the Ears, published by Sakura Shah in 2018. About the Vertigo Outpatient Clinic in the Department of Internal Medicine. The Vertigo Outpatient Clinic was established by myself in the Department of Internal Medicine at Yokosuka Kyosai Hospital in 1987, and it was closed when I resigned the hospital in 2005. Since then I have been providing vertigo treatment at Nukada Memorial Hospital in Kamakura City. I have been practicing vertigo for a total of 50 years, including my time in the Department of Otorhinolaryngology. I would like to refer vertigo patients who visit internal medicine outpatient clinics. Inner ear vertigo is not common in internal medicine. As for Meniere's disease, the rate is about 0.5% in general internal medicine, 5 to 10% in outpatient Department of Otorhinolaryngology, and about 15% including suspected cases in Japan. Otorhinolaryngology vertigo is often accompanied by ear symptoms, such as ear blockage, feeling of fullness, tinnitus, and hearing loss. Since the majority of patients in the Department of Internal Medicine are elderly, many of them have poor circulation in the vertebro-basilar artery and few have ear symptoms. This is an important but little-known fact. What is it? There is a considerable gap between the age groups of otolaryngology and internal medicine. According to a book by Professor Oda of Toho University, the frequency of elderly patients in the outpatient clinic of otolaryngology is 20 to 30%, and vertigo in the elderly is mostly centralized, with cerebral infarction and vertebro-basilar artery circulatory insufficiency being the most common causes. Recent data from an otorhinolaryngology vertigo clinic reported that 20.6% of patients were over 65 years of age. In the outpatient clinic for vertigo in general medicine, 62% of patients are over 60 years old, as shown in the graph. In otorhinolaryngology, there is a relatively young population, so naturally the frequency of ear-induced vertigo is higher. But in internal medicine there are more elderly patients, so inevitably there is an increase in central vertigo. 90% of vertigo is caused by the ears. If this concept is transferred directly to internal medicine, vertigo is considered to be caused by the ears when it is originally caused by the brain, and the probability of falling into a pitfall increases. The cerebellum and vestibular nuclei in the brainstem as well as the inner ear are involved in dizziness and nystagmus, abnormal eye movements. These three places are connected to the oculomotor nucleus, which is located in the brainstem. In addition, from the oculomotor nucleus, three cranial nerves go to the muscles that move the eye freely. In other words, the inner ear, the vestibular nucleus, and the cerebellum control the movement of the eye. Therefore, if any of these three areas is dysfunctional or impaired, nystagmus and vertigo will occur as well. For that reason, dizziness is not always an abnormality of the inner ear. Since the inner ear, the vestibular nucleus of the brainstem, and the cerebellum, especially the vestibulocerebellum, which is located under the middle of the cerebellum, originate and develop from the same place in the fetus, they are, so to speak, three brothers. Therefore, rotatory vertigo and non-rotatory vertigo are not necessarily caused by the inner ear. There are other ways to classify vertigo, but to make it easier to understand the nature of vertigo, it can be divided into two categories, that is, rotatory vertigo and non-rotatory vertigo, dizziness. What are the symptoms of non-rotatory vertigo? 1. Fluffy, wobbly, or a feeling of walking on clouds. These symptoms are called floating dizziness. 2. The view shakes from side to side. Feels like an earthquake. These conditions suggest cerebellar lesions. 3. Blackout darkness in front of the eyes. This is a symptom in which the field of view suddenly becomes completely black. This symptom is caused by ischemia in the occipital lobe of the cerebrum. 4. Fainting, a temporary loss of consciousness within a few minutes. Feeling faint, also called pre-faintness, this is caused by ischemia in the upper part of the brainstem. 5. Head being pulled back, objects shaking vertically. These conditions suggest a lesion in the brainstem or cerebellum. The following is an overview of peripheral vertigo, or inner ear vertigo. 1. Meniere's disease. The symptoms are rotatory vertigo with tinnitus and hearing loss. The duration of vertigo is from 10 minutes to several hours, and as long as 7 to 8 hours. The characteristic symptom of Meniere's disease is that once the vertigo occurs, tinnitus and hearing loss worsen, and the ear symptoms often improve at the same time as the vertigo subsides. Therefore, multiple vertigo or dizziness in seconds is not Meniere's disease. The prevalence of Meniere's disease is said to be 16 per 100,000 people.